My great pleasure being here today with all of you. I have to say, just going back to the previous presentation, that we do use a lot of natriuretic peptides, more and more, and we are having a problem in Spain that probably you don't have in Tunisia, which is that general practitioners, when they have the suspicion of heart failure, the time elapsed between the suspicion to echo sometimes is too long. It may be weeks to months. And we know now from the 4 pivotal trials that SGLT2 inhibitors are very effective in just 2 weeks. So if we confirm our suspicion with natriuretic peptides, I think we should start with SGLT2 inhibitors. But this is not the topic of my talk today. I'm going to talk exactly the opposite. I'm going to focus on HF-rEF, so how to titrate in 2023. And the guidelines are trying to make life easy for us because they no longer go in a vertical way. They put the 4 fundamental pillars, which are RAS inhibitors, ACE inhibitors, ARNI, beta blockers, MRA, SGLT2 inhibitors. And the guidelines just tell you do what you want. So that's why we're discussing today. If there is volume overload, you go with diuretics. The pathophysiology of ACE inhibitors and beta blockers, we know it very well because they have been here with us for many years, as well as MRAs. Let me just give you a few seconds of pathophysiology on the mechanisms of ARNI and SGLT2 inhibitors. So this is the pathway of neprilysin and natriuretic peptides. On your right, you see the receptor angiotensin II. And this, you see angiotensin II, which interacts with angiotensin I receptor. And these are the bad guys. As you can see, vasoconstriction, fibrosis, water, and sodium retention. On your left, you have natriuretic peptides, AMP, BNP, CNP, which interact with MPRA, MPRB, and they are transmembrane enzymes that transform GTP into cyclic GMP. Cyclic GMP is the good thing you want to have in the heart. You want high levels of cyclic GMP because then you have vasodilation, less fibrosis, less hypertrophy, and natriuresis. The problem is that these are hormones, and as such, there are mechanisms to remove them from the body quickly, and this is done by neprilysin in the setting of heart failure. So then is when we have sacubitril/valsartan. On one side, we block angiotensin I receptor, and we suppress the RAS, and on the other side, by blocking neprilysin, we enhance the natriuretic peptide system by prolonging the half-life of these natriuretic peptides, prolonging the interaction with the receptor, and therefore increasing cyclic GMP. So this is the mechanism of action. You all know that, but just as to refresh. It's interesting that we have now very good data proving, and that's the trial, Proof HF, that ARNI are important to reverse remodel the heart with HF-rEF. If you can see here, patients treated with ARNI ejection fraction increased in 12 months 9.4 ejection fraction points. This is a large number because these patients, they move from being REF to being mildly reduced, and some of them, they just move from REF to PEF. So this is very important. Volumes go down. Left atrial volume index is also very important because we didn't tend to think as atria to reverse remodel, and they do. And as you can see on your right, when you have patients that are naive to ACE inhibitors and you start with ARNI, in this trial, Proof-HF, ejection fraction improved from 28 to 44, so 7 extra points to those that already were on ACE first. So the other pathway is SGLT2 inhibitors. We all have heard about this. I know you're tired, but just 1 second. They block the proximal tubule receptor, then all this glucose that's filtered through the nephron, which are 100 grams per day, they are eliminated through the urine. Not all of it, a majority, 80 grams per glucose, are eliminated, and therefore you have glucosuria, but you also eliminate sodium, so you have also natriuresis. I'm just saying this because when you give these 2 drugs, ARNI, Entresto, or sacubitril/valsartan, or DAPA-EMPA, you need to remember that the 2 have natriuretic effects, and they are very useful to maintain or try to reduce the loop diuretics, which, as you know, they are going to stimulate the RAS system, and we get into this vicious circle. So this is important to remember. We did a study following the proof HF concept, which is a baseline and 6 month. We did 6 months, they did 12 months, and putting all the images analyzed together in a blinded fashion. And what we found with dapagliflozin is that at 6 months, this was particularly focused on LAVI. We wanted to know if the left atrial would remodel, and we see a 7.3% reverse remodeling of the atrium, but we did see left ventricular mass reversal, 13%, and as well end-diastolic volumes together with NT-proBNP. So this was a very interesting study that would provide us evidence to know where we are in HF-rEF therapies in 2023. So we want hard endpoints, survival, cardiovascular, and all-cause mortality. Morbidity endpoints, heart failure, rehospitalization, quality of life, very important in our patients, but also the evidence of reverse remodeling. So if you go to this table, ARNI gets the 4, SGLT2 inhibitors get the 4, ACE, beta blockers, and MRAs, the evidence on quality of life is not as robust as the others. It is true that these 3 other classes, they have not received all the attention of the last 2 classes, but we do not have such strong evidence. And we know that quality of life, sometimes when we do up titration of beta blockers, at the beginning, the patients feel a little bit worse. So that's something to remember. So how do we prescribe in 2023? We have these 4 drugs. We do the conventional sequencing, which is as they were appearing historically and the trials were done, which is on your left. You start with ACE inhibitors, or if not tolerated, ARB, up to the maximum dose. Then you go to a beta blocker, up to maximum dose tolerated. Then you put the MRA. If ACE inhibitors are not tolerated, you switch to ARNI, and finally SGLT2 inhibitors. This is what we used to do. Milton Packer and John McMurray say that this typically requires 6 months or more. How many of you used to do this? Because this was what the guidelines would tell us before 2021. I used to do that. I used to go 1 by 1. And without the SGLT2 inhibitors because they were not there, but we used to go 1 by 1. McMurray and Packer, they say, hey, let's do it faster. And they put a beta blocker and an SGLT2 inhibitor first, and then you go ARNI and then MRA. And this should be done within 4 weeks. So I would say the left sequencing, I think we should avoid it. We should forget about it. I would say the right sequencing may be an oversimplification of the problem. So let's look at it. So the Heart Failure Association of the European Society of Cardiology put forward this patient profiling, which I think it's useful just to understand where we go and just to keep us entertained for our particular patient. So this profiling puts in the center the 4 pillars plus diuretics, depending on congestion, and sets 4 important areas to care. Heart rhythm, CKD, no CKD plus hyperkalemia, AFib, no AFib, and blood pressure. So then you make all the combinations, and there are a large number of combinations here, but if you start looking at the different combinations, the ones that I put in the circles are those where you start with SGLT2 inhibitors, beta blockers, which is 60% of some of them. SGLT2 inhibitors, as you can see, they are valuable regardless of which are the combinations. If the patient is hypotensive, they are useful. If the patient has hyperkalemia, no problem. If the patient has AFib, no problem. So it's the first drug. In the second term, you can put beta blockers. If you have hypotension, probably MRAs as a second drug. If you have CKD, you probably will initiate MRAs a little bit later. But at the end of the day, you should try to put the 4 pillars. Following this profiling, the group from Savarese in Stockholm, taking the SWEET heart failure registry, looked into real proportions of patients. And if you look to real life, eGFR below 30, in our heart failure patients with HF-rEF, it's only 6% of the population, very low. If you look to AFib, it's 45, 55. That it's pretty much what we see in the clinic. If you look to hyperkalemia, over 5.5, it's just 0.6%. If you look to hypotension below 90, it's just 1.8% of real-life experiences. And when you look to heart rate, a HF-rEF patient, naive, very rarely comes with a heart rate less than 60 beats per minute. So what I'm trying to say with this is that probably the combination of SGLT2 inhibitors, beta blockers, is very safe in most instances. That's what I most often do. Then a week later, I jump with ARNI, and then MRA, I keep it to the end, because I always have the concern of potassium, but probably it's not necessary. So as a matter of fact, in 4 weeks, we need to try to put these drugs and then do the up-titration. We don't do as we used to do before, that you up-titrate ACE to 20 milligrams enalapril, and then you start with the beta blocker. No, we now think it's better for the patient to put the 4 pillars as soon as possible, and then you up-titrate depending on the profile. Can you please go back? Thank you. So, can you please go where I was? Are you getting me out of the session? I'm not sure if I'm done. All right. Okay, so until now we were talking about heart failure with reduced ejection fraction in the outpatient setting. What is the evidence that we have in the inpatient setting? So we do have evidence, and this comes from the STRONG HF study. In this study, patients with acute decompensated heart failure, both HF-pef and HF-rEF, they were randomized to 2 groups, standard of care and high-intensity care. The high-intensity care, they started with the triad RAS, beta blocker, MRA, because this study was initiated before SGLT2 inhibitors. And then they go week 1, week 2, week 3, up to week 6, up-titrating and checking for safety. They checked at 90 days, and they checked at 180 days to look for the primary outcome of heart failure readmission or all-cause mortality. So it so happens that in the acute patient, in red, you have high-intensity care. In blue, you have usual care. So look to bright red is half dose, dark red is full dose. So if you look to the strong strategy, which is intensive care, ARNIs, ARBs go up to 80% versus 30-35% at days 90 and 180. You get beta blocker going to 80% versus 30 to 40%. And in the case of MRAs, it's pretty much the same in the 2 groups, and the numbers are super high, over 90%. So what this study found is that the primary endpoint of 180-day readmission for heart failure or all-cause death was very statistically significant. And when analyzing one of the 2 components of this combined endpoint, which is all-cause death, that was non-significant. It appears that most of the benefit comes from hospital readmissions. So this study has been so impactful that the new update of the recommendations of the European Society of Cardiology has given it, if you can put full screen, sorry, I'm finishing, has given it a type 1B. Can you put the screen as full screen, please? Thank you. A type 1B recommendation. So, an intensive strategy of initiation and rapid up-titration of evidence-based treatment before discharge and during frequent and careful follow-up visits in the first 6 weeks following acute heart failure hospitalization is recommended. 1B. So, my last slide. In HF-rEF, in the chronic setting, in the acute setting, you put the 4 drugs in 4 to 6 weeks, and then up-titrate. Ideally, start in the inpatient setting when the patient is admitted, or the naive patient start quickly with the four drugs. Thank you very much.